Thank you all for coming to our breakout session. This is San Diego Fertility Center breakout session. So this is Dr. Saeed Danashmand. I'm Dr. Susanna Park. And we're going to run our format a little differently than most other centers, as you'll learn about in a second.
So we have a clinic right here, a lab here in New York City that we work with in terms of your sperm freeze. So if you decide not to come to our sunny, ocean-breezed, lovely climate San Diego Fertility Center for your sperm freeze, and we highly suggest you do and recommend you do because you get to meet the whole team and get to tour the facilities. You can freeze your sperm right here in New York City, and then we transport the sperm over to San Diego for fertilization of the eggs. So what we're going to do today is we're going to really open the floor to your questions, and you've heard a great deal of talks and talked to, I'm sure, many providers, so we feel like we want to answer your specific questions in the session that we have.
Any questions about anything? Yeah?
Just real quick, do you have any other clinics you work with? We're from DC, so
Yes, we do. We've worked actually with a clinic, for example, in DC and Chicago, where we can freeze your sperm and then transport the sperm over. One of the good things about having colleagues all around the U.S. and really having good relationships with them is that you can call them up and you can text them and say, you know, we have intended parents who are going to come to you and they're going to freeze their sperm. But I guess that means you don't want to come to our sunny, you know. And that's fine. No, yes, actually, DC, we have two good friends there that have fertility clinics, and you can freeze your sperm there as well.
One caveat, so the cost of shipping sperm is expensive. So when you look at the cost of shipping sperm versus the cost of an airfare to San Diego, you may change your mind. Any other questions about anything? All right, so I'm gonna, one topic that question I get a lot, and people are always confused about this, is what is the difference between this pre-implantation genetic testing and DNA testing? Okay, they're not the same. They're both types of genetic disorders, but they're not the same. So we all have chromosomes, 46 chromosomes, 23 came from the egg source, 23 came from the sperm source. Inside the chromosome is your DNA, how tall you are, your eye color, your hair color. And did you know we all have mutations in our DNA? Look how normal we all are, right? But some people have mutations, these are called autosomal recessive diseases, that if there's a mutation in one chromosome, and the opposite chromosome, which came from the opposite, in this case, the egg source, has the same mutation, then there's a 25%, then your child will actually be sick. So there's a 25% chance that a mutation from the sperm and a mutation from the egg will come together if both the sperm and the egg are carriers of this mutation. An example of this is cystic fibrosis, okay, or sickle cell trait. So DNA mutation is blood testing that's done on the sperm source and the egg source just to make sure nobody has zero mutations, but to make sure you guys don't have the same mutations. That's very different from pre-implantation genetic testing of the embryo. That you wait for your embryo is 5 days old, you take a biopsy, and all you're counting is the number of chromosomes of the embryo. Because cases like Down syndrome, those are not mutations in the DNA. Those are cases where there are too many chromosomes, in that example, chromosome 21. Or you can have Turner syndrome, where you're actually missing a chromosome X. So again, all of this result in disabilities, but two different types of genetic diseases. Okay.
And one of the advantages that we have is, as you know, we have the largest private clinic egg donor database at our center. And one of the advantages that we have is that all of our donors are pre-screened genetically before they're placed on the database. So if we have a donor, you, for example, select an egg donor and she carries a particular autosomal recessive mutation, what we then do is we send you a kit, a saliva kit, to test your mutations to make sure that you don't carry the same mutation. Because as Dr. Park said, if you do, then there's a 25% chance the child could get that particular disease. And these recessive mutations are diseases such as thalassemia, cystic fibrosis, hemochromatosis. These are all diseases that require a mutation to be carried by the sperm and the mutation to be carried by the egg. So that way we avoid you having to select a donor that you really like, and then later on finding out that she carries a particular mutation that you do, and then there's disappointment, and you won't be able to work with that particular donor. The other big advantage of having a clinic's own private database that's pre-screened is that we want to make sure that your egg donor has a sufficient number of good quality eggs, both quality and quantity. For many of you, when we retrieve the eggs, you would like us to divide the eggs between both of you so each of you has a certain number of embryos that we freeze. If you want to have 1, 2, 3 children in the future. So ensuring that the egg donor has a sufficient number of good quality eggs also ensures and maximizes the chance of success that each of you will end up with embryos. So that's another reason for having a private clinic egg donor database. And there's another advantage, and that is we don't charge for our egg donor database. So it's a sort of not an egg donor agency. It's really only for use for our intended parents.
Oh, yep. So it depends. So in our database, just like Asian donors, pretty low. However, we have a list of private egg donor agencies that we know will be able to get you African American donors. Okay? And so just to that point, what's the difference is there's just going to be an increased cost to the intended parent, because with a private egg donor agency, you have to pay the agency fee. And then you have to pay to get that donor medically tested. And then all of our donors live in San Diego. But if in this agency, let's say she lives in New York, you have to pay for her to travel to the medical clinic. Even though I know it costs more, it's more important that you pick a donor that is like the donor for you and spend that extra money than pick a donor you're just half-hearted about and say, sure, whatever, we'll pick her as my donor, right? Because this is your child for life, right? So it's worth the extra expense. You're welcome.
Yes. Those are two great questions. So how do we assess the quality of the embryo? Now, if I tell you, you won't come to the medical panel tomorrow, which we're speaking at, but I'll tell you anyway. So there are two ways in which to assess the quality of the embryo. In fact, we've published work on it. You'll be able to find it on PubMed.com. One is when the embryo, when the eggs are fertilized, it takes the embryos 5 to 6 days to make it to the blastocyst stage. In other words, they start dividing into 2 cells, into 4, into 8, to 16, all the way 100 to 128 cell embryo called a blastocyst. When they reach that stage, under the microscope, we look at their structural integrity. We look at specific objective parameters, like, for example, the diameter of particular cells, the level of expansion. Imagine the embryo is almost like a flower. It kind of blossoms out, and we look to see how blossomed it is, how expanded it is. So there are objective criteria by which then we assign a good or fair or poor assignment to those particular cells. And we look at 2 different levels of cells. We look at the inner cell mass, which are a group of cells that give rise to the fetus. And then we look at the trophectoderm cells, which give rise to the placenta and gestational sac. And that's directly correlated with the chance of implantation, the chance of pregnancy and delivery. And again, this is work we've published on. The second way to assess the quality of the embryo is to assess the quality of its chromosomes, or the complement of chromosomes. So we want to see, as Dr. Park said, 23 pairs of chromosomes. We want to see chromosome 1 all the way to chromosome 23, which are the sex chromosomes, all paired up. So what we can do is we can do a genetic analysis on the embryo and make sure the embryo is chromosomally normal. Having said that, when you look at chromosome analysis, it's much less useful when you are working with egg donors who are very young, because typically it's older women, especially women that are older than 35, that have a higher risk of having chromosomal abnormalities. So really, the best way to assess the quality of embryos when you're working with an egg donor is through that structural integrity under the microscope. We have patients, for example, who want to transport embryos from different parts of the world to us for transfer to a surrogate, because surrogacy is not allowed in most places in the world. And clinics have different criteria for assessing the quality of embryos. We don't use all of us as standardized assessments. So what I tell and what we tell intended parents is, show us the images. Every clinic should really take images of and photos of the embryos at the blastocyst stage. When we look at the embryo images, then we can make objective assessments at what the quality is, and then we can let you know, okay, if the embryo is this quality, this is the chance of pregnancy. Or if we transfer 2 embryos and each is high quality, then we're looking at a very high rate of a twin pregnancy.
I'm sorry, just to answer your second question about the sibling. So the question was, which is better, to have frozen embryos or separate egg, separate sperm? The answer is frozen embryos, because if you freeze an egg, frozen sperm does really well, right? But a frozen egg is very different. They're more sensitive, right? So a frozen egg, when you thaw it, has about a 70 to 80% chance it's going to survive the thaw, versus a fertilized egg where you put the sperm and the egg together, which we call an embryo, has over a 95% chance of surviving that thaw. Which is why we say, if you know both of you are going to want to be biological parents to the child out the gate, you should use both sperm sources and have your own separate embryos, as opposed to fertilizing half with one sperm and leaving the other eggs unfertilized. Did that answer your question?
You had a question there?
Indefinite, without a decrease in quality. I know, amazing, right?
We had a couple from Australia. The embryos were frozen for 20 years. They were frozen in 1999. And we thought, actually, they were frozen at an early stage. Because back then we used to just culture embryos to day 2 or day 3 to 8-cell stage. And we thawed the embryos and transferred one single blastocyst and have a pregnancy. Not always the case. I mean, 20 years is a long time, but at least we know that if they're good quality embryos, we can freeze them for a long time. And the techniques for freezing have now improved so much that the way we freeze now, which is vitrification, is very different than the way we were freezing 5 years ago. I believe it's about $500 per year, but I do think that when you initially start the cycle, I think for the first 2 to 3 years, it's already covered. So you only start paying for storage fees after the 3rd or 4th year, I think. But as our financial department tells us, talk to them, because the doctors know less about the financial side of things.
So you mentioned that with your techniques, you're able to check the quality of the embryo.
Mm-hmm.
High quality ones, you have better chances of taking. Have you seen that your rates, when you're able to do that, are higher than the industry standard, or what are your rates of success?
So in the egg donor surrogate world, which is very different than the 40-year-old who comes to see us struggling with infertility, 80. And when we transfer 2, it's about 90. And the twin rate is about 50%. So just remember, just transferring 2 is not a guarantee of twins. And earlier this week, I have a couple from men having babies in Florida. I transferred 2, pregnant, great. Ultrasound showed twins, and then her 3rd ultrasound this week showed that one had split. So they actually have triplets. It's less than 5% risk. But that's one of the downsides of trying to transfer 2 is you may end up with more than you bargained for.
Yes?
What are some good ways and criteria to evaluate your fertility versus others? Success rate?
So I used to tell my family and friends, don't go to a doctor who hasn't been in practice for at least 10 years. And then when I was at my 7th or 8th year mark, my family and friends would say, well, what about you? I said, well, I'm an exception to the rule. So, but I do think that experience is really important. I think you should ask our colleagues about us, because they know the most about us. If you go to the agencies that are here, the attorneys that are here, ask about our center. Ask about San Diego Fertility Center. Ask about Dr. Danishman, Dr. Park, Dr. Chuan, the other doctor. We have 5 doctors in total. And they'll give you feedback about how their experience has been. Talk to other intended parents, parents who've gone through the journey with us. And also research, to look us up in terms of the research that we've done, the publications we've had over the last 20 years. I mean, another part of a clinic or a physician profile that's important is also the work they've done over the course of years. So I think all of that is important. I think we bring to the table all of that. We've done a lot of research. As I told you, we're in the middle of doing actually a research on PGS. Looking at a non-invasive method of doing PGS, meaning not having to do a biopsy on the embryo. You will benefit from a clinic that's doing research because that's the only way to advance the science and advance the pregnancy rates and make IVF even safer. Because we want IVF to be safe for your egg donors and for your surrogates. So we, for example, publish work on ovarian hyperstimulation syndrome. So donors who come to us, they get a special protocol and they don't develop ovarian hyperstimulation, or they have a very, very low chance of developing that. So we want your donors to be healthy. And so I think that's another area. We're a clinic that's doing ongoing research. We just presented a paper at the American Society of Reproductive Medicine, one of our embryologists. That's how I think you gain an understanding. And there are other methods. I mean, you can do Google reviews and other things as well.
Oh, easy, right? So first is how do you get your sperm to San Diego? So let's say you said, all right, you know what? I'm not traveling to San Diego. I'm too busy. So go to our lab on 27th Street, give your sperm. They'll ship it to San Diego. Your egg donor then cycles in Texas, and we monitor from San Diego. They take meds for a week and a half. So after a week of meds, she then flies to San Diego for the last few days of her stimulation harvest. She flies back to Texas. We create embryos, we freeze. You've got your surrogate, right? She does the preparation in, where did you say she lives again? Connecticut. She does her preparation in Connecticut. And we manage it again. Once her lining is ready, she gets on that plane, flies to San Diego, we do the transfer. She flies in the day before the transfer, we do the transfer. Next day, she's back on that plane, back to San Diego. Most of our cases are exactly like this. It's very common. Easy.
Yes. There aren't. I mean, egg retrievals and egg donation is a relatively low risk procedure. I mean, you do have the very small risk of infection, but those are extremely low risk. We talk to egg donors about the potential risk, but really there's no risk to their own fertility. There's no long-term risks that we know of from egg donation. It's a very safe procedure. It's done under anesthesia. It takes about 15 to 20 minutes to retrieve eggs from the ovaries. We used to have a risk called ovarian hyperstimulation syndrome. That was pretty much the only significant risk with egg donation, but we've pretty much eliminated that by using what we call a GnRH agonist trigger or a Lupron trigger, which means that in order to cause the final maturation of the eggs, we use a medication that uses the egg donor's own hormones to mature the eggs, rather than giving her an artificial hormone to mature the eggs. The artificial hormone stayed in their bodies much longer, and it caused their ovaries to hyperstimulate, and then they would have fluid in their abdomen, sometimes fluid in their lungs, increased risk of having blood clots. And that was deemed ovarian hyperstimulation syndrome. So we have pretty much eliminated that risk, and that was really the only risk to egg donation. And if anything, if you have a friend who wants to donate, they'll also be able to gain a great insight into the quality of their own eggs and their own fertility when they donate.